Welcome to the Hospital Finance Podcast, your go-to source for information and insights that can help you protect and enhance revenue at your hospital. And now, the host of the Hospital Finance Podcast, Michael Passanante.
Hi, this is Mike Passanante, and welcome back to the Hospital Finance Podcast. Today, I'm joined by Dr. Barrette, who is the Director of Research at the Healthcare Cost Institute. Dr. Barrette's research is focused on the diffusion and impact of health information technology and geographic variation in medical resource use and prices. He's joined us today to discuss a new issue brief and tool from HCCI called the Healthy Marketplace Index. Dr. Barrette, welcome to the Hospital Finance Podcast.
Thanks for having me.
So let's kick things off. Just to set up the podcast, could you explain what the Healthy Marketplace Index is?
Sure. So the Healthy Marketplace Index is actually a series of measures or metrics designed to evaluate the economic performance of healthcare finance and delivery. So it was funded with some funding from Robert Wood Johnson Foundation. And if you think of their project, the Healthy County Rankings, it's similar in concept in that those rankings are a series of measures of population health. These are a series of measures of economic performance related to price, utilization, competition, productivity. And hopefully it's going to be useful in a similar way that the county health rankings are being used in a lot of ways today.
Great. So let's talk a little bit about the issue brief. Could you briefly talk about the data set you used in your analysis and the factors you looked at?
Yeah. So all of the metrics that we developed, the ones that were in the first issue brief and the ones that will be in the issue briefs that follow over the next few weeks, were developed with the HCCI research data. The data set includes 3 large insurers, United, Aetna, and Humana, who provide us all of their health insurance claims data, which includes the allowed amounts or the actual amounts that the insurers pay the providers. The data set is HIPAA compliant, so all the patients are de-identified. Providers are actually de-identified too, so we can distinguish between providers or patients, but we don't know who's who. And also, it's important to note the insurers' identities are masked, and we can't even distinguish between different insurers in the data. So we just see one large data set. But within that, because we have some member demographics, age and gender and location, as well as all their claims for all of their medical services that were reimbursed through insurance, we can do studies like this. So we focused on the 0 to 64 age group of individuals that had employer-sponsored insurance. And then we limited the analysis to areas where the HCCI data accounted for approximately 20% or more of the total employer-sponsored insurance population, just to ensure that we had sufficient sample sizes for doing the calculations. And then after that, the first issue brief, we calculated a series of price indices. So what we did was we created a bundle of the most common services based on all of the data that we were using for the study. So, for example, in inpatient hospital setting, we found the 100 most common DRGs, and then calculated a weighted average price for the whole sample, and then within each area that we studied. By doing that and calculating the weighted average off of a single set, or you might say like a basket of goods, we removed any influence of differences in utilization. So what we were doing was we're looking at just differences in prices this way. And we did that for 61 CBSAs, which are core-based statistical areas, or they're sort of defined by or used by the Census Bureau. You could think of them as metro areas. So there's a core metro area and the surrounding areas. It's based on where people live and work.
Excellent. So let's talk about your major findings. First, you noted that from 2012 to 2014, prices for inpatient, outpatient, and physician services all increased, but there are some nuances there. Can you talk about them?
Definitely. So, yeah, it's absolutely correct. All the prices have been going up over this period, 2012 to 2014, but they're going up at different rates, and I think that this is the first, I guess, theme that comes out of what our report is that when people talk about healthcare prices, it's important to note that there isn't just one price for healthcare. So looking just at the difference between the different types of prices, inpatient, outpatient, or physician prices, inpatient prices rose pretty steadily one year to the next. And physician prices increased the least, and actually they barely increased at all between 12 and 13 in our data, and just slightly the following year. And then the biggest increase was in outpatient prices. So our report was really designed to identify these types of trends, and not, we didn't go the step further to try and figure out why this might be going on. Our thought is that it's more important to get this information out, and then us as well as other people that have access to data or interest in these types of things can dig a little deeper. But there's probably more to be done in terms of trying to understand what's going on in the markets. But I think sort of the nuances you're talking about here are just that there's differences between service category types.
And to that point, you also found substantial variations within the service categories. What did you find there?
Yeah. So as I mentioned earlier, we looked across 61 metro areas, and there's a wide range. So the way we calculated the index, everything is sort of relative to the sample average or a national average. So we can say prices in one area. I'm actually in Milwaukee right now, so I can say prices in Milwaukee were X% below national average or above the national average. And what we found is that there is a range, from sort of 35% to 40% below average in some cases on the most extreme, to 60 some percent above average on the most extreme on the other side. So inpatient, outpatient, and physician all had a large range like this as well. So although they all had a big range, the distributions of prices did differ slightly. Getting back to my earlier point that there's differences between these service categories, not just in how their prices change over time, but how in a given year the prices are distributed over the same sets of metro areas.
And it looks like inpatient and outpatient prices tended to move together, while physician prices didn't follow in the same way. And you alluded to that earlier. Any thoughts on why that may be?
Yeah, I have a couple. Again, none of these have been really thoroughly tested, but in a lot of instances, outpatient facility services are provided by facilities that are associated with a hospital system. So if we're thinking about how prices are being set and being negotiated with insurers, in many cases, not all, but many times, inpatient and outpatient prices are related just because the hospital system is working out their prices across all of their services and in all of the ways they can provide it. And more generally than that, facility prices, one is inpatient, one is outpatient, but they're both facility-based prices, which is to say that those are more similar than physician prices are to any type of facility pricing. So I think there's potentially a couple things going on, but I wasn't surprised to see the relationship between those and less between physician prices. It's just a little bit unclear at this point, just because we haven't really looked at what the exact mechanism is that's tying the two together.
This is certainly an interesting issue brief, and I think forwards the discussion along, gives us all some things to think about. If our listeners would like to find out more about HCCI or get a copy of the issue brief, where can they go?
Sure, they can go to our website. All of the reports, this one and all the other HCCI reports, including the forthcoming HMI briefs, are available on our website at www.healthcostinstitute.org. There's actually a special section just for the HMI briefs that also has an interactive map, so you can change the years of the study and see how the different HMI metrics compare over time across the country visually. You can see what's above average, what's below average. But like I said before, all the other briefs we also have done are up there. So yeah, I encourage people to use the briefs and hopefully do follow-on research to help understand a little better what's going on in healthcare markets.
Dr. Eric Barrette, thanks for spending some time with us today on the Hospital Finance Podcast.
Thanks for having me.
If you have a topic that you'd like us to discuss on the Hospital Finance Podcast, or if you'd like to be a guest, drop us a line at update@bessler.com.
This concludes today's episode of the Hospital Finance Podcast. For show notes and additional resources to help you protect and enhance revenue at your hospital, visit bessler.com/podcasts. The Hospital Finance Podcast is a production of Bessler Consulting.